you everybody for being here today. That's awesome, and I want to thank our online audience as well. We had over 300 people register to be on today's program virtually from around the world, all right? And that's a great number. You hopefully made it to the exhibit room, and if you did, I just want to let you know that we had platinum sponsors today for this program from Bristol-Myers Squibb, Biogen, and Sandoz. Our silver sponsor was Memorial Regional Hospital, and our community sponsors are Sanofi, Alexion, Janssen, TG Therapeutics, and Horizon. Let's give them a round of applause. We have Dr. MITZI Joy Williams-Brown. This is a very special person. I really do hope that you could all listen with her and pay close attention. She is world-renowned, okay? She travels all over the world to do these educational programs because she's got a lot to say. Today she'll be speaking about new avenues of how they're treating in underserved communities and reducing the barriers, the ins and outs of telehealth, and she'll be speaking also about clinical trials. So she's going to speak for about 35 minutes, and then we're going to do a 25-minute Q&A. But now let me tell you a little bit about Dr. Williams. As I mentioned, she's world-renowned multiple sclerosis expert. Dr. MITZI Joy Williams-Brown is a board-certified neurologist, fellowship-trained MS specialist, an author, an international speaker, and researcher who is passionate about declaring and educating and empowering people affected by multiple sclerosis. Her specialized training and expertise makes her a highly sought after expert and thought leader in the field of neurology and multiple sclerosis, often called upon to speak nationally and internationally, as stated, on topics relating to advancing cases of MS care. She's the proud recipient of Multiple Sclerosis Society's Hope Award and the 2019 Black Doctor Organization Top Blacks in Healthcare Award. She's also the Amazon #1 best-selling author of MS Made Simple, the essential guide to understanding a multiple sclerosis diagnosis. And now I'm going to turn the mic over to Dr. Williams.
Stuart, thank you so much for having me. I wish that I could be there with you all in person, but still I'm very excited to talk about a couple of topics that are very near and dear to me. And Stuart always keeps me on my toes by giving me several different topics. So hopefully I'm going to get through them in these 35 minutes and then be able to answer some questions for you all. All right, perfect. Next slide. All right, so we'll start a little bit when we talk about underserved communities. I don't have the slide listed here, but underserved really could mean a variety of different things. You know, typically when we think of underserved, we think of people of different racial and ethnic minorities, but certainly underserved could be people who live in rural communities, LGBTQ plus communities. And so there are many different groups of people that have not really been brought to the forefront or may not receive the same type of care for their MS and other conditions as those who may live in certain parts of the country. So when we talk about a health disparity, which really is kind of why we focus on underserved populations, because there are health disparities or differences in the outcomes in those groups versus others. This is just a definition of a health disparity, basically meaning that there's a difference in the quality of healthcare that's provided, but it's not due to problems like, you know, actual differences in the disease. It's due to other things such as people's access to certain providers, differences in their insurance coverage, as well as potential discrimination they may face depending on what providers they encounter. So when we talk about particularly underserved populations, so my research focuses a lot on MS and Black and Hispanic groups. I live in Atlanta, Georgia, and I have a very large population of very diverse patients here in the city of Atlanta. And basically, when I came out of training, we thought that MS was a disease that primarily occurred in young white women. And although globally, that is still the case. Here in the US, there are studies that suggest that there is actually a much higher prevalence of MS in Black people than we previously thought. And so this was just a recent study that was published in 2022 from a group in Southern California that's just discussing, you know, and you can see the graphs here, that the bars between the white and the Black patients are very similar. So again, it's something that we're recognizing in different communities much more than we did even 10 to 15 years ago. Another point that I think is extremely important to point out, when looking at MS and underserved populations, is recognizing that, again, health disparities lead to different outcomes. And this is a very striking paper that was published in 2018 by my good friend, Dr. Liliana Amescua, looking at mortality from MS. And typically we don't think of MS as a fatal disease, right? We know that the lifespan of people with MS may be slightly shorter than those in the general population, but we typically don't think of it as a fatal disease. And so imagine looking at this data and seeing that at younger ages, the highest mortality from multiple sclerosis is in Black women and Black men. So under the age of 55 in Black women, and then under the age of 45 in Black men. And so when we look at differences in outcomes, right, there are multiple studies. I'm not going to go in a whole lot of detail in them during this talk because that's not the total focus of it. But there are multiple studies that suggest we see different outcomes in different groups, that there may be more progression of MS, particularly in Black and Hispanic populations, that we may see more severe disease even from the beginning. And when we look at issues related to that, we try to figure out, well, why is that happening? Is it something biologic, right? When we think about race is really a social construct. It's really not based in biology. But are there other things that are leading to it, like those social determinants of health that are causing health disparities? So this is a paper that looked at access to care and showed that African Americans were actually 30% less likely to see a neurologist in clinic. And this was not just for MS, but for general neurologic conditions, more likely to be seen in the ER, have hospital stays. So again, when we're trying to figure out why some groups have different outcomes, looking at information like this can help us to better understand a person's access to care. Also, this was a study looking at economic status, and so socioeconomic status, which is independent of race or ethnicity, certainly can impact people. If you don't have money to get to the doctor, that can be an issue. If you don't have transportation, things like that. If you don't have access to funds to pay for medications, all of these things can impact health outcomes. And this particular study looked at low socioeconomic status, basically finances, and suggested that it does seem to impact certain populations disproportionately or more than others. Particularly Black and Hispanic patients had higher morbidity, more complications of disease and mortality if they were also of lower socioeconomic status. All right, so back to the question. When we think about, health disparities, we think about underserved populations, we think about racial and ethnic minorities. How do we determine ethnicity, right? And so this is a big question, right? And when we talk about race and ethnicity, it is what we call self-reported. So if you say you are this, then that's what we go on, right? Where we really probably need to be looking at things on a more genetic basis or a more scientific level. Next slide. So why is race important then? You say, Dr. Williams, this is a social construct. It's based on geography, it's based on skin color, it's not based on biology. So then why are we talking about it, right? And the reason is because it does affect health outcomes. Next slide. So what are some of the barriers to care in diverse populations that certainly need to be addressed and are being addressed? Certainly systemic racism plays a role. Sometimes there's bias and misdiagnosis, particularly if doctors have a particular picture in their mind where they're looking at these patients and saying, well, this is what MS usually looks like and it doesn't look like this. So that may not raise suspicion in certain groups. There can be lack of access to care, lack of culturally competent care, particularly for those who may speak a different language. There may be difficulty with language barriers, as well as, in some cases, mistrust of the healthcare system, and also insurance being, not having insurance or being underinsured are all things that can affect outcomes. So this is, again, kind of looking at this in a broader lens, social determinants of health. And one of the ways that we help to better understand why we're seeing outcomes is research, which I'll get into a little bit later after I talk a little bit about telehealth. But these social determinants of health, again, really can impact outcomes. So healthcare is not just about how severe your MS is, how many relapses you have, how many MRI lesions, but all of these things, such as your financial status, your access to resources, your access to doctors that understand you, or other barriers, your literacy, your health literacy, all of these things play a part in how one person will do long term, if they'll do well with a certain condition, or if they may have poor outcomes. This is some research that was published focused on some of these issues and just looking at how they impact how people may do long-term with multiple sclerosis. So certainly education can play a role. So if someone is potentially less educated, they may have a lower health literacy, which could affect their ability to understand instructions for medications, et cetera. Also, access to specialty care. There are many people who may not be able to be seen by an MS specialist, such as those on the esteemed panel, that have been speaking with you all today. And some people may have neurologists that aren't very well versed in MS, and that can affect their outcomes. And then we talked a little bit about income and levels of employment, which can affect a person's ability to access care. So let's switch gears and talk about it. So what is one of the solutions, right? So we think about Dr. MITZI, we got all these problems that you listed. What can we do about them? Well, telehealth has been one potential solution to some of the issues that we've seen with access to care, although it does have its challenges as well. So when we talk about digital tools, we're in an increasingly digital society. So many things that we used to do manually or with our hands are now done by a computer. Even when we think about the healthcare system overall, all your doctors now have electronic medical records. I do remember in the Stone Ages when we used to write things down, and my handwriting is pretty bad, so I do remember when we used to write everything down and we had to read the notes in a physical chart that looked like a binder and flip the pages, and that was how we saw what was going on with patients versus being able to log into a computer and see all of that information. And we're seeing that information is being increasingly connected between different systems, hospital systems, so that we can really keep track of what's going on with you over the long run and over your different doctor's visits, especially if it's within the same type of healthcare system. So what are some of the digital tools that we use that can help improve delivery of care for people with MS? Certainly there's telemedicine, which we'll go into a little bit more detail about. There are apps, there are apps like MyChart where you can log in and look at your results from your tests. This has proven very helpful, particularly for patients who come to see, a neurologist, or when you have a new doctor and they may not have received your records, at least they can get some idea of what's been going on with you. Also, there are wearable devices. So this is becoming increasingly important in the role of MS care, trying to figure out how can we use this information to see how you're doing at home, because when you come in for one visit, certainly it's a snapshot. So usually when you're at the doctor, everything's doing great, but when you get home and you're trying to walk and you're having difficulty, we can't really see that in the 20 or 30 minutes that we see you in the office. So there's a lot of research that's looking into wearable devices like your Fitbits, like your other smartwatches, to see how we can use that information to better inform, how our patients are doing over time. And then also the personal healthcare records, as I said, are digitized, looking at virtual assistants, looking at ways that we can conduct some of our clinical research, and also things like cameras and things like that can also help us to make sure that we're delivering the best care possible, and to make sure that people have access who may not have physical access to a center with specialty care. So how can tools assist in real-time monitoring? Certainly, one of the difficulties with MS is that, it is a lifelong condition, and particularly if you're diagnosed at a younger age, there may be difficulty or challenges with adhering to a treatment plan long-term. So digital tools such as auto-injectors, right, really were a game changer when our medications first became available, because those auto-injectors made it a lot easier for people to take their medications versus having to pull needles and syringes and things like that. And then how can we also monitor how often people are taking their medications so that you'll know if you forgot, et cetera. So the use of these e-health tools can be really helpful in making sure that you're keeping up with your treatments, that you're doing things properly, and also can help inform your doctor of what's going on with you. Looking at things like our smartwatches and other digital health tools can potentially help monitor how your MS is doing in real time. Again, when we do your exam in the office, we typically do a test, or oftentimes your neurologist may do a test called an EDSS, which is a scale where we look at different parts of the neurologic exam and kind of come up with a score to let us know the level of disability, so to speak, of one person versus another. One of the difficulties with things like smartwatches is that it gives so much information in just 24 hours. How do we kind of narrow that down? And that's where other tools come in, where there are, apps that may look at specific functions or have you do specific tests and monitor them over time so that we can see how those things are doing at home. Other helpful things that have been used are things like cognitive testing. So there's even e-health tools where cognitive testing can be done at home on the computer through an email and measure your cognitive function. So again, I think that, many different practices are at varying levels of incorporating this information, but certainly as we move forward, in the future of the way we take care of MS, incorporating this digital information in some form will make a really big difference to help us to figure out how you're doing on a day-to-day basis at home, which may vary from how you're doing when you come in for that, 6-month or yearly office visit. So when we talk about telemedicine, telemedicine is something that I have personally been engaging in and using to treat neurologic patients for over 15 to 20 years. And so I previously did telemedicine in conjunction with stroke care because that's really where it came to the forefront. Patients who had issues or neurologic issues that were acute, you'd be able to connect them with a neurologist and we'd be able to see them and make decisions about their care to get them access to timely care. Since the pandemic, it's really become more in the forefront for conditions, chronic conditions like multiple sclerosis, where we're really trying to check in, see how people are doing, and also have access to them where you may not have to come into the office and you may not have to deal with, transportation issues and things. So there are many benefits. So for people living with a chronic condition like MS, certainly is increased access to care. In many cases, there can be information. Oftentimes, if someone is having an issue, we can hop on a quick televisit call to see if they're having a relapse, see if it needs to necessitate them coming to the office versus them having to wait maybe 4 to 6 weeks or even longer to come in for a visit and be seen. Also can help monitor and track symptoms and changes. For healthcare providers, it's also very beneficial too, because we can look at what interventions may need to be done. We may be able to do a quick follow-up for a medication check and avoid someone having to sit in traffic, particularly in Atlanta. We have a lot of pretty severe traffic, so that's definitely a plus for our patients. And it's an efficient use of time because usually if you're at home, we don't have to spend 20 minutes, talking about how bad the traffic in the parking lot was. So can be very, very helpful. When we think about the pros and cons of telemedicine, now telehealth can include a variety of things. So telehealth and telemedicine can include those face-to-face visits where someone's on the camera, like I'm on the camera looking at you, but also can include telephone calls. And that may not be as effective. So in many cases, in some settings, people did not have the technology to be able to see people face-to-face. I think that the pandemic really kind of sped the use of that technology up. And now there are many platforms that people can use where it is safe, where your information, where it's compliant with patient privacy standards, but also where you're able to kind of see your doctor face to face and they can do some exam with you. So when we talk about telemedicine, I'm speaking more from a vantage point of this type of visit where I'm looking at you, the patient is, looking at me, and I can examine them and interact with them and or their families in whatever setting they're in, usually at home. So, definitely there's some pros to that, right? It could save you travel time, can save you gas, right? Gas is very expensive. Can also keep you from having to go into a setting where you may be exposed to, different germs, right? It is flu season. And so certainly not having to be in a large room full of people who may have certain illnesses could be helpful. And also for those who live far away, you can have access to a provider. So for many states, as long as you and your doctor are in the same state, they can see you, even if you live 3 or 4 hours away. And if your doctor has a license wherever you live, then they can see you in those areas too. So it can be be very convenient. However, there are some cons to telemedicine, right? You still may need an in-person visit. Your doctor can only do so much over the computer. We can't get a really good, thorough exam on you. So we do need to lay hands on our patient, so to speak, at some point, because we need to get a good exam to see what's going on with them so we can monitor progression over time. In some cases, some people aren't as good at telemedicine, you know, so some people haven't been using it for a long time. Some providers are not as adept at using it, and so in some cases it may be better for you to receive that care in person. And then also in some cases with telemedicine, particularly platforms, you may not be able to choose who your provider is. So, you know, I have colleagues who work on different platforms, you know, and particularly when I worked with stroke patients, they don't get to pick what neurologist is, whoever's on call that day in whatever city, wherever they are. So you may not have a choice in some cases of who you get to see and who you interact with for your care. So those are certainly some cons. So I think that telemedicine is here to stay. But certainly, you know, we have to try to optimize and make the most of each of these telemedicine visits. Now, I think it's really important to think about tips for a successful telemedicine visit. And you may have heard this periodically throughout the pandemic, but I think the first most important thing is to prepare for your visit. So you know, I'm a firm believer that, you know, you should prepare for your visit just like you would an in-person visit, right? So if you have a list of questions, if you have a list of concerns, those things should be kind of right there in front of you and ready to go when you're getting ready to log on for that telemedicine visit. Also, a list of your current medications is important. Some type of writing pad or whatever you use, smart device for notes can also be very helpful. It's also important to make sure your device is charged up. There's nothing like being in the middle of that conversation with the doctor and your phone is going dead. And then also being in a quiet, well-lit place. I think that you know, we do a lot on the go. We do a lot of moving. We do lots of phone conversations. Everybody's had the person in Walmart that has their phone on speaker and you hear their whole conversation throughout the store. But you don't want that to be the case with your doctor's visit. You know, so if you can take a break from wherever you are at work, not be in a crowded room, and make sure that you're in a quiet, well-lit place so you can have the best effective interaction. I think that that's extremely important to having a successful telemedicine visit. And I think one of the other pros is also if you're at home or in your home environment, sometimes other family members can be there to participate in that visit as well. So that's telemedicine, right? So certainly, you know, as I said, there are many health disparities that need to be addressed. I think that telemedicine is one way we can address some of those. There's certainly many others that need to be worked on. And one of them that I'm very passionate about is increasing diversity in clinical trials. So one of the challenges when looking at population, so I kind of set things up in the beginning of the talk where we talked about how there's a certain face that people assign to MS, which is usually that of a young white woman, but there are many different faces of MS that we're seeing now, particularly here in the United States. And so when we try to understand why we're seeing maybe increased risk of MS in certain populations, why people may have worse symptoms, and we try to go to our scientific papers to better understand that, we don't have a lot of research to help us understand. This is a publication, if you've ever seen me talk before, you probably have seen a slide similar to this, where we looked at all the literature that was written about multiple sclerosis. This is back in 2015, which was probably the Stone Ages compared to now. But we looked at over 60,000 articles and only a little over 100 were about minority patients, Black and Hispanic people with multiple sclerosis. And the research for other populations such as Native American or, you know, Asian American is even less, if almost non-existent, right? So there's a big problem in us needing research to help us better understand MS across all populations, because ultimately we want to be able to treat and apply everything to everyone that we see. And if everyone is not a part of that research process or a part of that conversation, then when we come with the solution, it's hard to know if the solution applies to those groups of people. When we look at our clinical trials for multiple sclerosis, they're conducted primarily in Eastern Europe. And so they're very small. There's much smaller numbers of US populations in our clinical trials, which means even smaller numbers of diverse groups. So this was a study that looked at, many of our major MS clinical trials, and the enrollment of Black patients was anywhere from 2.3 to 16%. The majority of those were more on the 2.3 end, okay? Was only one that had 16%. And then for Hispanic patients, 7 to 7.5. And in some of our earlier studies, they didn't even ask ethnicity, so we don't really have that data available to help us understand who was in the clinical trials. I think that when we talk about clinical research, and even when we talked about barriers to care in underserved populations, it's important to acknowledge that mistrust does exist, but it is not something that cannot, in some cases, be overcome, I would say. And when we think about mistrust, in order to understand why certain communities are one way, it's important to understand the history. The book that I have here on the left hand, or left for me, or the right hand of the slide, is called Medical Apartheid, and it's a very fascinating book I would encourage anyone to read, that talks a lot about the historical mistreatments of particularly Black Americans in the United States in clinical research. And then there's a picture in the middle of one of the fathers of OBGYN who did his experiments on slave women without anesthesia, and that's how we learned a lot about the female anatomy. And then, of course, on the far end of the slide is a picture from the Tuskegee syphilis study, which was a study conducted in the 1930s that basically followed Black men until they died from syphilis. And initially, when the study was done, it was done without their consent. But initially, when the study was done, there was no treatment available, so it was an observational study. The ethical issue came into play once the cure for penicillin became available. It was withheld from these people, and they were continued to be observed until they died. And so again, when we think about many of the issues related to mistrust of research and things like that, they are often well-founded, but again, cannot be overcome. And this is a great paper that was published in conjunction with some of my friends from the Accelerated Cure Project. And we looked at a survey and asked people about their interest in research. So we surveyed Black, white, and Hispanic people living with MS. And what we found was that overwhelmingly most people were very interested and had positive views of research, and that they were also interested in being involved in research. There certainly were some concerns in the minority community, such as mistrust, concern that they may receive poor care, or for those who are immigrants, that it may affect their legal status. But we found that two of the largest reasons people didn't participate was, number one, they did not know where to find out about trials, and number two, they were not asked. And so again, there certainly are some barriers or some concerns about research involvement, but there are many who want to be involved in research but aren't asked. So how do we solve this problem, right? Certainly there are many, many great minds, much greater than mine, that are working on solving these issues. And one collaborative is the Advancing Inclusive Research Council, which is a group that I work with of many different oncologists and other physicians working in this space. And there's some recommendations. I know you can't read them. I know you want me to read that tiny print to you, but I'm going to resist the urge. I'm not going to do it. But essentially, what this paper was trying to depict is that it's really a multi-pronged effort. It's a multidisciplinary effort. It takes a village of us to try to figure out how to solve these issues, right? And also how to address health disparities. I think the first thing to recognize is that we can't blame the people with the condition for the health disparities, right? So we have to look at it in particular in terms of research of not just a matter as people not wanting to participate, but they're not being enrolled for a variety of reasons. We have to look at the way we conduct our research, right? For, again, underserved populations, which can include ethnic minority populations, but also rural populations, right? How do we get people access to these studies? How do we make it easier? How do we use these digital health tools to give us information and take some of that burden off of people who want to participate in research, but may not have the resources to travel 4 or 5 hours to a center to get certain tests. And so, I think there are many that are looking at really kind of renovating or thinking outside of the box about the way that we conduct research, so that, again, we can make sure that the people that are in our studies really represent the people in the real world who are being treated for these conditions and being treated with these medications and interventions. One project that I'm very proud of is the CHIMES trial. It is the first clinical trial that is focused on Black and Hispanic people with multiple sclerosis. And again, in thinking outside of the box and how we approach issues of involvement in research, one of the things I think is really important is the way that we try to approach doing the trial. So we had a collaborative approach from the beginning. We had patients who were involved in the process of creating the protocol, or helping with the tests and things that we do for research. We had members of the MSAA. We also had people from the Accelerated Cure Project, as well as our Advancing Inclusive Research Council. And then also materials that were created for the study were vetted by patient advisory councils. And so again, looking at how can we collaborate to make sure that we are delivering care in the right way, that we're asking the right questions, and that we're reaching the people that need to be reached. And so this was really a very interesting endeavor, and we wound up over-enrolling for the study with just Black and Hispanic patients with MS, who many say or would say do not want to be involved in research. So we're very successful in enrolling and getting this study off the ground. So when we think about research, again, many of the barriers to healthcare for underserved populations are very similar as those that are barriers to people being involved in research. So number one, we talked about how people are not invited to participate, maybe because there's an assumption that they will not be compliant or that they won't come to the visits. Also, there's a lack of awareness. So if you're not being seen at a large academic center, you may not be able to have access to trials. That's why platforms such as Stewart's, MS Views and News is so important, because you get access to these, people who are in the top of the field, and you also get information about the research and other things that are being conducted in the MS community. Also, there may be factors or perceptions. People don't want to be experimented on. We saw a lot of, difficulty with vaccine hesitancy in terms of the COVID-19 pandemic, and people are very concerned about the things that they put in their bodies, and rightfully so. And so we have to make sure that we're providing accurate information for those who do want to participate and be involved in research. Certainly, we need to make sure that we make it less of a burden on those. We talked about financial and logistic burdens. If you've got to travel to your MS center 3 or 4 hours away, it may not be feasible. If your MS center is 15 minutes away and you have a job and you have a life, it could be very difficult to do that on a regular basis and leave your regular activities to be able to participate. And then I think we have to address issues of mistrust generally within the community, and also particularly in some of our underserved communities, as well as look at the inclusion and exclusion criteria for trials, meaning looking at who we allow in and who we don't. Because in our clinical trials, we often try to have, people who are pretty healthy otherwise, so that, we know that the results of the study are actually due to whatever intervention we're doing. But in the real world, people with MS have high blood pressure, they have diabetes, they have these other conditions. And so we want to make sure that we know how to treat these patients, and we know the effect of MS in these groups, so that we're not experimenting in the real world, so to speak, as opposed to learning more about these in a controlled setting of a clinical research study. What are some resources to find out about research? I'm so glad you asked. So this was a project that was put out by the Office of Minority Health and Health Equity, and I listed on the right here some websites that you can look at to see if there's clinical research in your area. And again, clinical trials are not for everybody, but there are many different ways to be involved in the research process. There are surveys, there are registries, there are studies where people are looking at diet and exercise and other interventions to see how they affect people living with MS. And so, my encouragement to everyone, so to speak, is to get in where you fit in. And so these are some resources that can give you more information about research, about where to find out about research, particularly in your area. And if there is an academic center, like an MS center at a hospital locally, those are always good resources to find out about clinical studies that are being conducted as well. So I'm close to the end here. I think I even gave a few minutes back, but there's a quote that I love by Maya Angelou, and it says, "My mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style." And I would say the first point of thriving is really seeking out information in forums such as the symposium. I'm so proud of the work that Stuart is doing, and so excited to be asked to come and share some information with you all and hopefully answer some questions. These are some educational resources, particularly for patients, all patients with MS, but some are, have information for patients of color. And so I listed those here. And of course, you can see, I don't know, MS Views and News is not on, okay, it should be on this slide. All right, next slide. And then this is how you stay connected with me. I'm the Nerdy Neurologist. And my final slide that I always end with, which is the next one, is all I need is peace, love, and a frickin' cure for multiple sclerosis. Thank you guys so much for your time and attention. And again, I wish I could be there with you all, but I'm happy to ask some questions. And I'm so grateful Stuart asked me to speak.
Thank you very much. And we will, I can't believe you don't have my logo again.
I know, it's on my other slide. It's on my other slide.
I don't know, I'm gonna start removing slides from your presentations.
Don't do me like that, Stuart. Don't do me like that.
Okay. We'll take care of it in Atlanta, all right? All right. First one. What do indigenous people do who have multiple sclerosis? Where do they go for help?
Yeah, so that is an excellent question. So there are some neurologists that I know of, I believe with Cleveland Clinic in Vegas, in that area, that are trying to reach out to the indigenous community. I think one of the challenges is, accessing patients, particularly those who are on the reservation. Many of them may not go to academic MS centers. So I think that, there definitely needs to be a focus on making sure that we don't make minorities a minority, right? So typically when we say minority, we talk about Black and Hispanic patients, but there are many other groups that are very underserved, and the indigenous community is one of them. And so I think that there are efforts from, many of the researchers in those areas to try to reach out to see how can we make sure people are getting access to care. But I think certainly contacting, our patient-run organizations such as MS Views and News, our National MS Society, and other places are ways to start for people to find out what specialists are in their area and how they can gain access to care with some of those specialty centers.
Thank you. And where are the people going to from the Latinx group of people with multiple sclerosis in the United States? Are there any centers that they can go to or call upon for more information?
Yeah, so there is a group. So there is a National African American MS Registry, NAMSAR, that's focused on Black patients with MS, but there's also a Hispanic consortium. It's called AHRMS, ARMS. And Dr. Liliana Amescua, who's at USC, is one of the primary researchers. There's also Dr. Angel Chinea, who's in Puerto Rico. There are some physicians who are in Miami as well. And so that is a consortium of researchers who are interested in learning more about MS in the Hispanic population. And so starting with that group may be a good place to start to get more information. There is not as much in terms of advocacy groups that I'm aware of. For instance, there are online Black women support groups. I'm not aware of similar resources in the Hispanic community, but certainly starting with the registry, and also the MS Society has information, and they actually think they were doing their first Hispanic Latino Experience Summit online, so that may also be a place to get resources as well.
Hi, thank you. I was just wondering if you feel there's anything in the MS community that is being overlooked that maybe more MS support groups could reach out to help if there's like loss of information or medication or things like that.
Ooh, honey, do you have another hour? We don't. I think that there are lots of things that do need to be addressed. I think that one of the areas for support, I think that there are people who need support in different ways. And so one of the areas where I find there is a need for increased support is for some of my patients who are still working, who are kind of in that, phase of their careers and raising their children, who may not plug into our traditional support groups due to time or due to feeling like they may not be able to identify with some of those there. So I definitely see some areas there where there's a need for increased support. And certainly there also is a need for increased support amongst our underserved, particularly rural populations, people who can't get out to maybe attend some of our traditional areas. So there's a lot that needs to be addressed, but I think that, we start one thing at a time. And I think that, when each of us are passionate about an area and we focus on that area, then all the areas get covered.
Will the insurance industry continue to pay for people who need telehealth?
That's a great question. Right now they are in some areas, it is preferred. So sometimes when we get some of the claims from insurance companies or, they ask, can this be a telehealth visit? So right now it is. I'm hoping that that's a trend that will continue, but there is a lot of concern that it may not, right? So one of the reasons that telehealth was not particularly implemented in areas like MS is that insurance companies wouldn't cover it. And so I think there are many advocating. There are now telehealth societies, the American Telehealth Association, and others that are really pushing to make sure that telehealth not only is here to stay, but that physicians and other providers are compensated, for providing telehealth, which is really a service to the patients. A lot of my patients love telehealth. I got to beg them to come in now, but they like doing those visits at home. It's very convenient for them.
I want to ask you, how does people find out about the clinical trials?
Yes. So I had a slide up there. So clinicaltrials.gov is difficult to navigate, and so, the first thing I often recommend is if you're interested in clinical research, often at our large academic centers, clinical trials are going on. There are many private practices that also do clinical trials. So particularly if you're being seen at an MS center, usually there may be some research going on there. So that would be the first place to inquire. Also, academic centers in your area, such as your universities, often are also doing research. If you want to just kind of do your own research online, there were a couple of websites that I listed. One of them is called CISCRP, CISCRP, which is a group that's trying to raise awareness about clinical trials. There are also some new sites that are popping up where you can type in your zip code and your condition and see where clinical trials are being conducted. I think it was Clinical Trials Match. But that, and then also looking at advocacy organizations like yours, Stuart, like the Society MSAA, they sometimes have sections on their websites where they will list clinical trials that are being conducted and where they're being conducted.
Okay, thank you. I'm going to get to the person in the audience there. I see her hand up. I'll be there in a minute, but on my way, let me have Dr. Williams answer what your position is on medical cannabis.
Yeah, okay. So let's break it down here. Now, we can give a whole hour lecture on that too. But so, there is medical cannabis or marijuana, which many people often, which primarily I think in most people's mind is the smoked form of marijuana, right? Traditionally has been used for conditions like cancer, now has come more to the forefront with MS. I am more of an advocate of people using forms of CBD, which is kind of the therapeutic component of, marijuana, but doesn't have as much of the THC part, which kind of gives it the smell and also gives people some of the high. The reason I'm more of an advocate of CBD is because traditional marijuana, particularly when people smoke it, can affect their cognition. And cognition or cognitive problems can be an issue with multiple sclerosis. So, we don't want things that are making you slower or, able to function less. I think there are a lot of companies that are making different forms of CBD. It can be edible. There are pills, there are creams, there are tinctures. And so I have many patients who feel significant improvement in some of their symptoms, like spasticity, like pain, etc., when using THC products. I do have some that smoke, and again, although that's not my primary recommendation, I do have good success with using CBD products in many of my patients.
Okay, from the audience?
Why are the clinical studies or research limited to ages 18 to 55?
Excellent question. So another underserved population is people who are over the age of 55. And let me just be clear, 55 is not old, okay, just to be clear. So I think that, again, one of the issues that we run into with many of our studies is that they're trying to get this what I would say pristine population, right? So people that really just have that condition, may have some disability, but the goal of it is noble, to try to ensure that whatever effects we see are effects from, that medication or that intervention and not related to other issues like diabetes, hypertension, etc. One of the issues with aging is that our immune system also ages. It's something called immunosenescence. So basically, our immune systems don't work as well as they used to. And so the concern, I think, why people haven't been involved traditionally is that they don't want to kind of affect the results with the possibility that maybe your immune system is aging, not working like it's supposed to, and we won't see the full effect of certain medications. With that being said, our newer trials are going up to 65, and there are several large studies at some of our academic centers looking at what happens to MS treatment in groups that are over the age of 55. So people are now looking more at aging in MS, but I think that it definitely is something that needs to be rectified in expanding the ages of those involved in our clinical trials.
Hi, I have a question, not only people over 55, but I think there's a growing group of people that are retired and have MS over 65, and not only for research, but also for advocacy and support and treatment, because there's a whole array of things that start happening when you're over 65 that are related to age-related stuff and MS, and how do you tease that out?
Yeah, and so that's also an excellent question, and it's difficult, right? So particularly for my women who are going through menopause, teasing out what's the menopause versus what's the MS, can be difficult. There is research that is looking at, kind of particularly for women's health across the lifespan. To look at, how we can tease out some of those differences, but it definitely is a group that is underserved and does need to be addressed. I think, again, there are efforts looking at this, but there is still a lot of work that needs to be done in making sure that we don't, overlook. And I think one of the issues is that traditionally, MS was thought to kind of burn out after a certain age. I remember when I was coming along in training, and Aaron probably remembers this too, the doctors would say, oh, over the age of 50 or 60, MS burns out. We don't really need to treat it, meaning it's just very stable. There's nothing going on. And we're finding that that's not the case. And so I think that maybe that myth may have perpetuated overlooking some of these populations because they thought that it just stopped being active and didn't do anything after a certain age, and you didn't need to do anything about it. And we know that's not true.
Okay, thank you very much, Dr. Williams. We are out of questions, and I do want you to know that I have a plaque here for you. It's got your name on it, okay?
All right.
Thank you very much for speaking at this program, and I will mail it up to you, and hopefully you'll get it soon, okay? Plus, I just want to again thank all the supporters who I mentioned earlier. I'm not going to say all their names again. And I do have to thank greatly Orlando Production, my production team, who follows me around the country as we do all of our programs, handles everything virtual. And as you can see by all this equipment, it takes a lot to do all of this. All right, so let's welcome and say thanks to Orlando Production. And also, I have to thank all of you. All right? All of you online, thank you. All of you that attend our programs, thank you, because I couldn't do this if we didn't have people to do it for, right? So I do want to thank you all. All right, that's it. It's a wrap. Say goodnight, everybody.